Care Center. I'm our Care Center moderator this morning, going to be helping out. Just a few quick housekeeping items before we get started. If you have any questions during Dr. Lega's presentation, you can go ahead and add those to the chat and we'll make note of those during the session. We are recording now, just a reminder to everybody. In this session, it looks like you do have the option of turning camera on. The handouts and PowerPoint and slides, the recording will also be available later. And just a reminder that there will be a survey at the end of the session, and we do warmly ask that everyone fills that out. It does help us do better in the future, and also it helps us with our project here. So welcome, folks, and just to reiterate, if you have any tech issues during the session, you can feel free to message those in the chat to Brooke, who's our CVent co-host today. And I think if we'd like to go ahead and move on to disclaimers. So just our very boring disclaimers that you've all heard at this point. The training is offered through the Crisis and Recovery Enhancement Care TA Center, which is funded by the California Department of Healthcare Services and administered by the Center for Applied Research Solutions. Views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the California Department of Healthcare Services. In the case of any security issues that may occur, which I don't believe has happened during this conference, the session will immediately end and will not resume, and we'll send you a separate email with further instruction. We do invite you to use the chat box. You can add any questions or reflections throughout the session. Please use I statements and avoid making comments that are stigmatizing or otherwise injurious to others. If you experience any tech challenges, again, Brooke, our CVent co-host, is able to support, so you can just place a message in the chat box. We do ask that you please follow the community agreements and reach out for support if you need it by contacting a support line. If you need to step away from the session and would like to go to a quiet place within the conference for self-guided grounding, please go ahead and exit from the session and go to the exhibitor booth entitled Calm Space. And then you can also come back into the session later if you would like to do so. Now it's time to begin our presentation. We're going to have some time for Q&A and I think discussion during the presentation as well. And again, at the end, we will drop in that survey request inviting your feedback. And again, I'm very pleased to invite Dr. Ruby Lega to introduce yourself.
Hi everyone, my name is Ruby Lega and I'm here today to talk about 5 core tenets pertaining to an anti-racist approach to mental health care. A little bit about me. I am a board certified child and adolescent and adult psychiatrist. Much of my recent work has focused on anti-racism in healthcare. If you're interested in learning more, here's a list of some of my works. For anti-racism work, what is perhaps more important, however, than my professional qualifications is my positionality and how I move. I have no financial disclosures. I did receive an honorarium of $1,000 to speak today and believe it's very important for individuals doing this work to know the exact ways in which it is monetized. Many axes of power and privilege open the door to this opportunity. I am a cisgender, heterosexual woman. I am a daughter of Punjabi Sikh immigrants, spared the structural racism of redlining, a beneficiary of the violence of colonization. I'm speaking to you today from my home that I own on stolen Tongva land. A disclaimer about language. I will be using racialized terms such as Black, white, minority, minoritized, BIPOC, and people of color. These terms are, of course, our instruments of communication for dialoguing about racism, anti-racism, and white supremacy, but they are also instruments of oppression as well, and the risk of their use must be stated explicitly. Today, I hope to provide you with some basic tenets and scaffolding for an anti-racist approach to mental health care, not only for yourself, but to share with others as a specific and immediate strategy for beginning to reimagine mental health care as an anti-racist practice. Each of the steps require extensive knowledge. Today's presentation is cursory, but these papers, all of which are available online, delve into the steps in greater detail and magnitude. To guide today's conversation, I'd like to start with a couple of minutes of discussion. You're welcome to use the chat option. Kim is also going to help me call on people as they raise their hands. The prompt for our discussion is, what is an anti-racist approach to clinical care and why is it important? I see in the chat that somebody wrote that it's critical to healing. Absolutely. Thank you for that. Any other thoughts or reflections about what an anti-racist approach to clinical care is and why it's important? Mm-hmm. See some of the comments coming in. Critical work as we move towards health equity, key stress reduction strategy, creating a safe and supportive environment with trust, truly listening to a person's life story through their historical trauma. An anti-racist approach would be awareness of potential bias and listening to patients with understanding and empathy. A way to meet people from where they, oh, these are great. Thank you for your patience while I keep up with all of these. These are great. Keep them coming. A way to meet with people from where they are and accepting how they want to proceed. Ask everyone treated about their trauma history. It's important to facilitate empathy and understanding. Builds a clinical rapport. Whole person care. Recognizing systemic violence and racism as leading factors to mental health. Meeting people where they are at without stigma or bias. These are so great. Creating connection and recognizing the mutuality of healing. Fighting to get the underserved what they need, just as everyone else is entitled to #equity. Everyone deserves a great care provider, but especially underprivileged. It allows for inclusion and acceptance of diversity, acknowledges the inequity that exists and how it impacts us all, divulging our history, a way to consider the trauma from racism to improve the well-being of our community. Anti-racism approach is important to healing. This is great. So I could read these for the rest of the presentation. Thank you so much. Keep them coming. Kim's going to be helping me keep track of the chat, and if there's a series of comments, she'll call on me and let me know. But this is a great start. So in addition to all the wonderful reasons that you provided about why consider an anti-racist approach to clinical care, let's talk about a few more. So from a research scholarship perspective, which is certainly not the only one, we have decades of research justifying why anti-racist clinical care must be the standard of care. Racism and white supremacy in their myriad forms yield devastating health inequities. We know this. Clinical care is not only not immune to oppression, it is a conduit for it. Our existing strategies and approaches, many of which have been forged by the white hegemony of the medical profession, have done little to shift health inequities. Furthermore, few, if any, anti-racist strategies for anti-racist clinical care have been developed or formalized. The original version of this slide featured an image of Daniel Prude and his brother Joe, but it had to be taken down for copyright concerns. I want you to imagine their faces and reflect on their stories. In March of 2020, Joe Prude took his brother, 41-year-old Daniel, to a local psychiatric facility to be evaluated for suicidal ideation. Daniel was discharged only to be killed by the police shortly thereafter when Joe Prude called the police during a mental health emergency. Joe Prude later said, quote, "I placed a phone call for my brother to get help, not for my brother to get lynched," end quote. We don't need decades of research to justify anti-racism in clinical care. Our definitive proof and evidence lives in this story and the immeasurable harm Daniel's lynching will cause his family and the community for generations to come. To be clear, anti-racism during clinical care is no substitution for reparations, policy, and other structural reforms, but it is one tool providers can use to take immediate responsibility for the lives before their eyes. By identifying the racism and white supremacy living and breathing within themselves first, and recognizing how it assaults their patients' lives, providers honor their oath to protect rather than harm. So to be clear, anti-racism is our oath and our imperative. Let's take a look at step one of this 5-step approach. Anti-racism is predicated upon a recognition of one's own racism, and when we refuse to make this admission, we are more likely to engage in racism and harm rather than protect our patients. So why admit to being racist? To paraphrase Ibram Kendi, the heartbeat of racism is denial. We hurl racism and white supremacy and cover it up when we use socially and professionally sanctioned terms that indict humanity, obscure oppression, and allow us to get away with it. There are a number of examples in terms of policies. Clinical examples include labeling individuals as malingerers, oppositional, and non-compliant. We have to admit to racism because it is denied by strategy. We see this obfuscation, denial, and cover-up in practice guidelines put forth by the leading mental health organizations in this country. All 3 of these organizations issued compelling statements about racism in the past year. The first 2 practice guidelines make no mention of racism whatsoever. The 3rd document makes a single mention of it in the final paragraph. So we see very clearly in mental health racism's obfuscation and denial. We're going to take a look at a brief video by Ibram Kendi highlighting the dichotomy of racism and anti-racism and why it's so useful for admitting to racism as a prerequisite for engaging in anti-racist clinical care. I'll just take a moment to pull up the video now.
My name is Ibram X. Kendi, and I'm the author of How to Be an Anti-Racist. And this book really seeks to show that the contrast is actually not between racist and not racist, but the contrast is between racist and anti-racist. What I think many people who self-identify as not racist don't realize is that really over the course of history, nearly every group of people that we actually consider to be racist have also identified as not racist, whether that's white supremacists today or segregationists of yesterday. And so really, each of us should be striving to be anti-racist, not necessarily striving to be not racist, because really that's a term primarily of denial, and it's a term really that doesn't have much meaning. But it does mean something to be racist. When someone says that there's something wrong with a racial group, they're being racist. When someone says there's nothing wrong with any of the racial groups, they're being anti-racist. When someone supports policies that create and reproduce racial inequity, they're being racist. When someone supports policies that yield and create racial equity, they're being an anti-racist. And these aren't necessarily identities or fixed categories or tattoos. Literally, what we're doing in each moment determines who and what we are in each moment. And people change from moment to moment and from year to year. And I think we should identify people based on what they're saying and doing, because no one ever becomes racist or even anti-racist.
So that dichotomy is so helpful in terms of thinking of clinical care because it's so oriented around actions, and one can begin to think about how every clinical action is either racist or anti-racist. That dichotomy is really helpful in terms of thinking of the practice guidelines. So one thing I encourage everyone to do is whenever you have guidelines or any kind of work that's related to clinical care, do a scan and look to see how many times racism is mentioned, white supremacy is mentioned. If we think about Kendi's dichotomy of racist or anti-racist, the denial or lack of acknowledgement of racism or the need for anti-racism is racist in and of itself. So, admitting to being racist, this dichotomy of racist and anti-racist, as I said, it's not only useful for clinical care, but this admission of being racist aligns with the piles of research about the neurobiology of racism and its growing recognition as a global public health concern. Healthcare providers carry so much power, especially in mental health. To not engage in anti-racism is therefore to default to racist clinical care. Our leading mental health organizations have not yet given us the guidelines for defining what anti-racist practice looks like. Hopefully the basic tenets we described today at least provide a starting point. Step 2, slow down and pause to heighten race consciousness. So the research shows that implicit bias is a neurobiological reality indicative of deep racial socialization and a human tendency to categorize. The fast automatic brain governs most behaviors. It works from unconscious associations and beliefs that drive discriminatory behavior. Our slow, more deliberate, and thoughtful brain, which can challenge these biased behaviors, is activated far less frequently. Stanford psychologist Jennifer Eberhardt's work has demonstrated how pausing long enough to heighten race consciousness can check implicit biases driving discriminatory behavior. For example, the Oakland Police Department's inserting a single question regarding the validity of police stops resulted in a 43% decline in the number of stops involving Black drivers over the course of 2 years. This neurobiological perspective is helpful, but to be clear, cursory checks and single questions cannot supplant the profound self-work required to heighten race consciousness. These two resources guide the kind of self-work that's needed to actualize this pause in clinical care in a substantive way so we can engage in anti-racist clinical care in a meaningful way. Let's return to the case of Daniel Prude, just to be clear that this isn't just about theory and neurobiology. These pauses can be about life and death. So this is an image of Daniel Prude and his family. I'll scroll down here just to kind of reflect on his care. When Joe Prude called Rochester, New York police to report his brother missing, he was struggling to understand why Daniel Prude had been released from the hospital hours earlier. Joe Prude described his brother's suicidal behavior. He jumped 21 stairs down to my basement head first. The train missed him by this much, Joe says, holding his thumb and pointer finger a few inches apart. When the doctor called me and told me they released him, I'm saying, how are you going to sit here and tell me you're going to release him when he was hurting himself? Come on, you weren't sworn to do that. So again, this isn't just about neurobiology. Simple pauses are not going to change anything, but one has to wonder whether or not the providers who provided that care that day stopped to pause and think about what it would mean to discharge Daniel Prude home from the hospital when he wasn't yet stabilized. Next step is to name and identify the racism and white supremacy shaping clinical care. Diagnosis determines treatment. Racism is, of course, incredibly complex. It operates on multiple different levels. Dr. Camara Jones' framework capturing internalized, interpersonally mediated, and institutionalized or structural racism is most frequently cited. Kendi's scholarship highlights racist policy and ideology. This table that I created is available in one of the papers I highlighted at the beginning of the presentation. And And I think this multi-level framework is particularly helpful for thinking about how these different forms of racism come together in a single clinical care encounter. So I highlighted some of the examples of the myriad forms of racism governing care. It might involve racist abuse by providers, including colleagues, healthcare as a form of structural racism itself, mandated reporting of child abuse, which can serve as a mechanism for regulating Black and Brown children and families, the adultification of minority youth and corresponding innocence of white youth, the white dominance of leadership governing systems and institutions and decision making. So again, these complex interrelated forms of racism can collide during a single clinical encounter between a provider and a patient. And we'll now take a look at a couple of cases to think about this a little bit more. Nurses inject a grade school Black child with intramuscular antipsychotic medication for agitation with no additional justification or effort to use less restrictive measures documented in the chart. They do not deliberate whether their pro-white implicit bias or anti-Black anger and adultification biases have influenced their decision to use unnecessary force. The child remains sedated and uncommunicative for 24 hours, and no one informs her mother until the following day. No scrutiny of this clinical decision-making transpires despite the well-established disproportionate use of violence and punishment directed against Black children and the heightened risk of traumatizing this young child as a result. Here's another example. A 17-year-old white child who has consistently refused therapy, medication management, and school is the focus of a cross-team meeting between wraparound, child and family services, and other mental health staff. They meet to discuss possible residential placement. Nearly a dozen providers deliberate for over an hour about her care and emphasize protecting her autonomy and rights, highlighting her trauma and her need to be in control. There is no consideration of the whiteness impairing care, including white privilege, captured in the form of a disproportionate allocation of time and resources dedicated to this child, the white privilege and normativity of not setting limits and boundaries to support her health and well-being, and the predominance of white staff in the meeting, which could be influencing clinical decision-making. So I think a lot of times with anti-racism in clinical care, there's a tendency to think about it only being pertinent to people who are not white. It's important to think about anti-racist clinical care being relevant in terms of disproportionately privileging, prioritizing, and allocating resources and time to white children as well. Next step. The history of white supremacy in shaping mental health care is crucial for anti-racism work. One of the shortcomings of my scholarship at this stage is emphasizing primarily the legacy of slavery. More deeply committing to emphasizing the legacy of colonization and settler colonialism as well is an ongoing part of my work and neglected in the papers of mine that I shared for this presentation. A recent New England Journal of Medicine article commented, quote, "Slavery has produced a legacy of racism, injustice, and brutality that runs from 1619 to the present, and that legacy infects medicine as it does all social institutions," end quote. It infects clinical care too. Biomedicine does not hold the key to revealing this legacy. The social sciences do, and these are several examples of some outstanding books that can deepen one's knowledge and awareness of this topic. Here's several more digestible pieces of information regarding the legacy of slavery. A talk I gave about the legacy of slavery in medicine and psychiatry in particular is available online if you're interested in watching it. While this presentation is brief and could not do justice to this profound history, we can emphasize some key arcs which are highlighted here. They include a long history of physical exploitation and human rights abuses, scientific racism, a narrative of racial difference and biological racial difference in particular, denial and segregation of medical services, white male predominance, silence regarding injustice and a failure to atone, and also a history of Black physician activism. In psychiatry, these arcs take the form, for example, of racist diagnostic practices rooted in slavery, indicting Black humanity instead of the white supremacy causing harm, perpetuating a narrative of Black criminality and violence to uphold racist policies like the war on drugs, remaining silent regarding racial terrorism, and engaging in medical exploitation and abuse, for example, the fenfluramine study in New York in the 1990s. These are several antipsychotic medication ads from psychiatric journals from the 1970s. They are flagrantly racist and anti-Black. They are juxtaposed against images capturing the white supremacy of the same era that so many Black psychiatrists were indicting, but that organized psychiatry, as part of its legacy of slavery, never condemned then or now. Final step. First, do no harm. Prevent and challenge racism and white supremacy in clinical care. So some strategic points that were highlighted in the two cases and captured to some extent in the story of Daniel Prude's lynching. Of course, avoid racism and white supremacy at all costs. This sounds so basic and simple, but we have to think back to the major mental health practice guidelines not speaking to this. And so it has to be stated so explicitly as we start to reimagine our practice as an anti-racist one. It's important to keep in mind preferential treatment of white patients is also a form of racist clinical care. Anti-racist clinical care, therefore, avoids it. Naming racism and white supremacy should be vital signs. They should be requisite parts of our clinical dialogues and conversations about care. We can also think about countering historical arcs as part of our anti-racist strategy. And we always have to bear in mind that impact matters more than intentions. And there's a biological basis for that. We know that the health consequences of racism are mediated through perceived discrimination. A lot of times people will distract from racism's harm by talking about intentions when it is irrelevant. Some additional strategies to bear in mind: avoiding patient blaming and racist diagnoses, being aware of the myriad coercive measures we have access to in mental health that can and do function as conduits of our and our colleagues' racism and white supremacy. Again, a patient's perception of mistreatment is more important than the provider's opinion regarding whether the patient has been mistreated. Daniel Prude's lynching reveals to us how listening and minimizing concerns are potentially deadly. And we have to be so careful with the language that we use in our charts and presentations. Even common practices like using racial identifiers or using terms like malingerer, non-compliant, oppositional, angry, are all potentially racist and highly racialized terms. A final word on strategy. I mentioned this before. Racism and white supremacy should be part and parcel of all case discussions, presentations, and clinical dialogues. Our language creates our reality. And I'll go back to the practice guidelines that we cited at the beginning. When there's no mention of it, there's no work that we can do. And so we have to start to get really comfortable naming and identifying where racism and white supremacy are at work and how they are at work in each and every moment. That's really our foundation for using actions that are anti-racist rather than racist. So let's close with some limitations for this approach, of which there are many. So as I said before, this is one immediate step that people can take. It certainly is not any kind of proxy for the structural reforms that are needed. It does not adequately confront white supremacy in clinical care. And as I said before, my papers highlight the legacy of slavery in the profession in particular and do an inadequate job of exploring the legacy of colonization and settler colonialism. Finally, this approach does not adequately address other interlocking systems of oppression, including but not limited to cissexism, heterosexism, ableism, and ageism. But it is something you can do immediately when you leave today to honor your oath and to honor Daniel Prude's life. please feel free to reach out if you have any questions or concerns. Thank you so much for starting off this presentation with such a great chat. There's some references here listed, and I'll move on to the questions and discussion.
And if anyone would like to raise your hand using the reactions, I can point you out. It looks like we've got a question chat. What is the first step to change?
Well, that's such a great question. I'd certainly be curious to hear what other people in the audience think. One of the things that we emphasized in this approach, at least, which is one, is admitting to the racism and white supremacy that exist. So whether it's the first step, it certainly is a crucial step before any action or change can be made, is sitting with what actually exists, and also deep historical understanding and recognition of what has happened up until now to create what exists now. I wonder if people have thoughts or reactions to that. I'm going to try to say your name, and I hope I say it properly. Lana, just noticing what you comment on, how it's a very dense presentation. It is so much. And so the 5 steps, I mean, even the idea that these are tenets or that they're somehow basic, it's hard to, it's almost does a disservice to kind of present it in such a cursory way, because each step requires so much knowledge and expertise to kind of synthesize it and put it together. So this is absolutely a starting point and scaffolding, but each step really requires so much deeper and more profound work. Jessica, I see your question about other terminology that would be better alternatives to oppositional. And again, I welcome other people to respond in the discussion. This is such a great question. So there are some papers out there about oppositional defiant disorder and other conduct disorder diagnoses being disproportionately applied to people of color. I guess the question that I always ask myself whenever I see this diagnosis with children, which I rarely, if ever, use, is what are children opposing, or what are people opposing? What are they opposed to? And that inevitably leads me to look at the systems of oppression that people are coming up against. So again, I think if we think about the legacy of racism in the mental health profession, there has been a focus on indicting individual behaviors instead of indicting larger systems of oppression like racism and white supremacy that are impacting behaviors. So that's how I tend to think of it, is what is the person opposing? Oh, go ahead.
No, I just wanted to make sure we saw Merced County had another question about change from an organizational lens as well.
What does change look like from an organizational lens? So there was actually, I'm going to go back a couple of slides. There was a paper that I cited here. It's by Dr. Rhea Boyd, called The Case for Desegregation. And it's right here. It was an article in The Lancet. And I think it's an incredibly helpful one to look at. because it sort of names the many elements of whiteness that shape different inequities. And I think it's a good starting point for thinking about first the problems in organizations that are preventing any meaningful change. So I would recommend looking to that article as a starting point for that. And then the name of the two readings, let me go pull that slide up really quickly. So it's Me and White Supremacy by Layla Saad, and then the Racial Healing Handbook. I hope I pronounced their name correctly, Annalise Singh. Access to slides and references. Kim, I believe people will have access to that after the presentation. Yes.
Yes.
Great. Let me look at this next question here. I've talked to other parents, and a lot of our children are asking us, does my life matter? Has anyone else run into this, and how do you address this in a way that the language can be respectful to the movement as a whole and yet infuse our children with importance as well? I wonder if anyone else wants to respond to that. I mean, I would certainly love more context around this question. It's such a rich one. I have so many questions about the context in which that question emerges, but I'll try to come back to it. And maybe Kim, you can make sure that I circle back to it. I guess what immediately comes to mind is a question of what is happening in our world to lead so many children to ask this question about whether their life matters when children are born with a sense of value, and that's chipped away at as time goes on. But would love to hear more about that question to fully understand it. Question coming up of how can we help our children feel safe and secure? The first question that comes to mind for me is what is a question about what is making children feel unsafe and not secure. Drawing from my own clinical practice, thinking about children being in communities and schools in particular, at least some of what I'm seeing recently is the extent to which young people and children do not feel safe in school settings, in which they're subjected to so many carceral and punitive practices there, and where the legacy of white supremacy infuses educational practices, disciplinary practices, so many practices. From my own experience, I'm seeing so much of that getting in the way or harming children in terms of their sense of safety and security, as one example. And then in terms of how to counter that, I think with thinking about clinical care, there's so many things that we have to think about for this. And clinical interactions are one interpersonal interaction, but there are much larger systems at play as well. So many things are coming to mind about what needs to happen in order to help children feel safe and secure. And I guess I'm reminded about how limited a biomedical framework can be in terms of trying to create that safety for children. Many children learned about George Floyd and became sad in the mood. Yeah, of course. Another question is, have you noticed community-based programs able to provide psychiatric care that is responsive and anti-racist? This is a great question. Um, so I think uh, this is this is tough. Um, and I go back to the practice guidelines that I showed at the beginning. And I often do this. If you just go to the American Psychiatric Association and pull up the most recent practice guidelines and do a quick search to see if racism or white supremacy are even mentioned, they're not in there. So the training and the established practice guidelines are not set up to train psychiatrists to be anti-racist. And um, I think it's also really important to think about the perspectives of people who are traumatized by psychiatric care and psychiatric systems. So there's a great article that came out. It's online, and it's about how abolition must include psychiatry, and it incorporates a disability justice perspective to critique the profession, and emphasizes some of the historical arcs that I talked about, talks about psychiatry's carceral practices, um, the ways in which it's enmeshed with the carceral system in this country as well. So I say all this to say that there are so many things about the way business as usual in the profession is set up to not make the profession anti-racist, that it's very hard for me to say, whether I've seen any model practices that are anti-racist in this profession. Any other comments or questions?
And for folks who might be listening in, we do have a link to all of the presentation slides is now dropped in chat for you.
Thanks for all the comments. I'm watching them as they pop up. I appreciate it. I see the comment. Thank you for your commitment and passion. Of course. Thank you all so much for showing up. Thank you all. Thank you for the comments.
And as we're wrapping up discussion a little bit, I'm going to go ahead and drop that attendee feedback survey. And again, if you could fill that out and let us know how wonderful you thought this presentation was, that would be great.
Thank you all so much for coming today, and I will go back to some of the original papers that are here, which are a nice starting point if you want to read or think about this some more. Um, the health affairs article is pretty brief. The public health post article is quite brief. And then the third article, which is in Psychiatric Clinics of North America, has some of the one of the diagrams that I showed and is a much longer, kind of very academic paper, a little less digestible, but it might be more relevant to your needs. So if you want to learn more or probe any of the slides further, I'd recommend that third article for further exploration.
And I'm just doing a final check here just to make sure we haven't missed any raised hands, but it doesn't look like we have any folks waiting to ask their questions.
Well, I'm here, and please feel free to reach out after the presentation if anything comes up. Let me go to the last slide so people know how to reach out. Thank you all for participating in the conversation via chat and for all of the great questions and comments. Really appreciate it. Thank you.
Thank you all again for, oh, we have one more question.
Great. Okay, how would you respond to government-funded mental health organizations that identify anti-racism as political or utilizes inclusion as a means to uphold the status quo, meaning that anti-racism is acknowledged as a political topic, therefore there are challenges in taking an explicitly anti-racist stance? This is such a great question. I think it's such an important one as well. Um, I think there was an article in the Lancet that came out um, in 2020 sometime. I believe it was called Racism, the Public Health Crisis We Can No Longer Ignore. And it literally addressed this, and and I'm just paraphrasing because I can't remember the exact quote, but it talked about how healthcare providers can no longer be technocratic and apolitical as their default, to sort of suggest that anti-racism is political, meaning that to not engage in anti-racism is not political. So I think what Amanda, you're naming here is the language that is used as part of the cover-up to avoid anti-racism as a healthcare imperative. And I think this point that you're making about the political statement, it sort of speaks to how there's this sense that science and objectivity are somehow the goal. And there's so much social science scholarship about how all of this language really centers whiteness and normalizes whiteness as the norm, and anything that deviates from that is wrong somehow. So, oh, thank you so much, Kim. Yeah, so I think that article is a great place to start. And then I think just naming that this is a very common strategy and it's an instrument of white supremacy to squash racism as a increasingly recognized public health concern. I think some of the arcs that we traced here, like the history, the legacy of scientific racism, the legacy of slavery and colonization in the profession, this all speaks to how this is sort of the language of denial to obfuscate and obscure racism as a public health crisis and as a clinical imperative. So highly recommend that article as a starting point.
Looks like we had one other question come in about small organizations, how they can support people.
So I'll read it. How can small organizations support and help people through their journey with mental health institutions? I work at a small nonprofit that works with people who use drugs and experience mental health issues. I would love to know how non-mental health professionals can support people. This is such a great question. I think one thing that immediately comes to mind is that I think people who engage the mental health system don't get the full informed consent about what's involved. So even though we have a huge body of literature just demonstrating how racist and coercive care can be, people are not warned of these things. So one of the slides that I had in here that I took out because I wasn't sure I'd have time to cover it, it featured a slide about a training in reporting to Child Protective Services, which healthcare providers are mandated reporters. And I had next to it a slide about the racialized nature of reporting, and how Black and brown children and families are disproportionately reported by a long shot, and how this pertains to a longer legacy of family regulation and disruption in this country. I mean, Dorothy Roberts and so many scholars have written about this already. This is nothing new. And none of our notices of privacy practices talk about this. So if you look at all the informed consent forms that people complete to engage in care, nothing talks about these really well-established literatures and research showing how much care is infused with racism and how damaging it can be. So something about people having the full informed consent about what it means to engage in this mental health system, I don't think people are given that option. And then the other thing that comes to mind is finding other alternatives. So disability justice frameworks, I think, are important. So there's an organization called Project Let's that emphasizes peer mental health support. There's a movement in California, Community Alternatives to 911, where they're trying to build community action teams to support people who are experiencing mental health crises. And some of that is in response to Daniel Prude's lynching. So I think that there are community-based efforts and initiatives that are coming up to shift things out of the mental health system, because there have been so many criticisms about how carceral the practices are. I'm not sure if that answers your question or if you have any follow-up ones for that. Thank you for that question. Okay, and somebody was saying, Amanda, you were saying, I don't feel like there is such a thing as an apolitical stance. By not addressing racism, it is definitely taking a stance that speaks volumes to those we serve. Yes, yes. Okay, and here's another question. Self-care as a practitioner is becoming so difficult in this climate. I am one of few that are able to engage Black community in my area and have been sent to hills where clients like me, but are themselves consistently making offensive comments and practicing their white supremacy on me. It's really crazy. Okay, yes, absolutely. So I'm so glad that you raised this. I'm actually working with a group of medical students on an anti-racism curriculum, and I'll be giving a talk about it this afternoon. One of the steps that we actually speak to is the treatment of providers. So most institutions do not have policies about people directing racism and white supremacy towards providers, which is racist and white supremacist in and of itself to have not policies in place. And these are acts of violence that are directed towards people. So I absolutely hear that comment. And I think, of course, there's a need for the structural reforms and changes. So this is completely unacceptable. These are violent things. And then I think an immediate strategy, which doesn't address the structural piece and the policy reforms that are needed, is connecting to a community and network of people who see this happening and who understand it. So I know that doesn't fix things, but the blows are even more devastating when they're not named and acknowledged. So to be able to share it with people who recognize and name that this is a problem, not a problem, an act of violence. So I hear this loud and clear. Yep, so community alternatives to 911. And then if you just Google, if you do a Google search for responses to Daniel Prude's lynching in particular, there are movements coming up. Like there's a program in Oregon called Cahoots that's gotten quite a bit of attention for trying to not involve, I believe they're trying not to involve police officers in their care. I think Denver or Colorado has had some programs where they're trying to create alternatives to police getting involved with mental health emergencies. So there's definitely that aspect as well. And then disability justice and abolition in mental health and psychiatry, lots of organizing and community-based efforts happening there as well. I think we're down to a few more minutes, so we'll just see if there are any other questions or responses.
Ruby, I know you asked us to, if we could loop back to that question about children asking, does my life matter?
Yes. Yeah, I'm coming back to it. Has anyone else run into this, and how do you address this in a way that the language be respectful to the movement as a whole? Yeah, I wish I had more context. I feel like I would need to understand um, the slide that I was showing about axes of power, privilege, and oppression. I would personally need to have a better understanding of what those axes are at play for. I would sort of need to better understand the context here of what's happening in that child's life to start to make sense of that. That's how I would be thinking of it. I haven't had any child ask me if their life matters. I've never had that specific question. But this is sort of the context that I would be seeking to understand where this question is coming from. All right, I think we're about to end. So nice to see everyone. Thank you so much for all these questions and for staying until the end. Thank you. I see all the comments. Thank you.
Thank you so much for the wonderful presentation and everyone for your wonderful questions and comments. If anyone missed the link to the slides from the presentation, those were emailed out to participants, and I believe that the link to the Google Drive with all of the session slides will be emailed out to participants again. And you can also access a recording of this session and other sessions through the Attendee Hub. Alrighty. Thank you, and I believe Brooke will be closing out the room for us.